We wanted to make sure that we had representation in terms of measurement-based care in practice in substance use. And so we have with us Dan Reck, who is the CEO of MATClinics, to talk about what's going on with them. Thank you, Dan. You're on.
Hi, everyone. Thanks for having me. My name is Dan Reck, and I just want to introduce you to an objective outcome measure that we developed at MATClinics for the treatment of opioid use disorder. We've chosen to promote the quality measure rather than keep it to ourselves, and we'll be publishing the details over the next few months. And just to be clear, we're happy to share our methods and results with anyone who's interested. We're not trying to keep this proprietary and sort of do anything to try to profit off of this. We think that this could be really useful for the industry. Next slide. Yeah, thank you. Page 2. So just some quick context. We're a specialty provider of addiction treatment in a physician office environment. Provider groups like ours are often referred to as OBOTs, or office-based opioid treatment. We offer a range of services from the core prescribing of medications to treat addiction to counseling and psychiatry, with case managers tying it all together. Next slide, please. So as our practice grew, we quickly ran into a problem. Patients were seeing a number of providers, each of whom differed in their interpretation of stability or adherence. So how could we provide a consistent patient experience? While there are a limited number of patient-reported outcome measures for addiction, there's no measure based on externally observed variables, at least that we could find. Given the nature of the population that we treat, we needed a way to assess patients, and we couldn't find an objective, externally validated quality measure. Without some standardized scoring of patients, we struggled to figure out how to responsibly grow and scale the business. Out of that necessity came our effort to build our own measurement of treatment outcomes. So throughout this presentation, I'll use a lot of terms interchangeably: outcome and quality measures, scores, predicted adherence, stability. To me, they're all effectively the same thing, an objective measure of how a patient is doing in treatment at any given point in time. All right, next slide, please. So some quick context for those of you who may not be steeped in addiction treatment. Our medical director analogizes patients starting treatment to a rookie pilot trying to land a plane without an instructor. Some patients start treatment and then drop out. Many others relapse during treatment but continue to make it to their visits. Others reduce their use of opioids but struggle to attain abstinence. And some respond immediately to treatment and are able to abstain from use. It's difficult for providers to know at what stage a patient is in their recovery from just a brief office visit, text-based toxicology results, and a scroll through historical notes in an EHR. Next slide, please. Before we had a way to objectively measure patient stability, there was far too much volatility in our patient's treatment experience. Most addiction providers have limited training in addiction medicine, and in our experience, make very different determinations based on similar patients presenting with similar histories. So we hope that there was something better. It turns out that our patient mix is very similar to most treatment providers. 70% of patients in treatment for OUD are stable and visit only monthly, or in some cases less often. This cohort of patients are too often triaged to inpatient and residential facilities without first engaging in light touch outpatient services. On the other hand, the remaining 30% of patients need more than a regimen of outpatient medication appointments. And we needed a way to objectively identify which patients needed the extra attention and resources. And importantly, we wanted to understand where each patient stood at each appointment. Patient trajectories can be volatile and it's easy to miss the signs of relapse. Next slide, please. So our solution: we utilize the information that every treatment provider collects and built a scoring methodology to identify which patients are stable and which are struggling at each appointment. Next slide, please. We always knew that there must be something to be learned from all the information our patients generate during their treatment. To that end, we collected and analyzed the data trail from over 3,000 patients and more than 50,000 appointments. Our data scientists utilized machine learning methods to build an algorithm based only on urine toxicology results and appointment compliance. We define the outcome measure as the likelihood that a patient shows up to the next appointment negative for opioids and positive for the prescribed medication. Just say that one more time. So adherence in our model means that at the next appointment, urine tox results would be positive for buprenorphine and negative for all other opioids. Next slide, please. So once we had the data and patient outcome measure for each appointment, we needed to make it easily digestible for our staff and providers. Again, the objective for us was to identify which patients need extra resources to assist in their recovery. For most patients, medication alone is sufficient, and there's no good reason to force them into time-consuming and expensive extra services. Next slide, please. So here are 3 patients as seen through a rudimentary dashboard we built in Google Data Studio. It's not that pretty, we're not software developers, but it's sufficient for our needs. If you look at the top left, this patient is stable in her treatment, and we should make sure that her visit is as quick and simple as possible. We know that she's doing well by the indicators in the dashboard. The top line is her adherence score, which is consistently high. Below that is a graphical representation of her medication adherence, illustrating that she's positive for the prescribed medication. Below the green and blue boxes indicating the presence of buprenorphine is an empty area that would be lit up if there were illicit drugs or other prescribed medications that concern us. Finally, the graphs at the bottom show appointment adherence. The one on the left represents medication visits. The one on the right shows counseling. The stable patient shows up for medication appointments, but we do not expect her to do any counseling. The other 2 dashboards show patients who are either consistently struggling to stop using opioids or have a pattern of relapse. Luckily, both of them are consistently taking their prescribed medications, giving them important protection against overdose. The 2 patients on the right get lots of attention from our case managers, providers, and are assigned in intensive outpatient counseling, which they both attend, as you can see from the bottom right green bar graph. The outcome measured, the line at the top, consolidates all the information below into a single number for each appointment. And importantly, our dashboard is used by our staff, our counselors, our case managers, as well as our medical providers. The adoption of the score and dashboard across staff helps to ensure that patients receive care appropriate to their current level of treatment adherence. Next slide, please. I'm likely preaching to the choir here, but we would love a world where we can compete for patients based on the quality of treatment we provide. We think we're good at what we do, but since others don't share their outcome results, we don't actually know whether we are better or worse than the rest of the industry. Next slide, please. Portability. So one of the critical objectives of our scoring methodology was to make it simple enough that anyone treating opioid use disorder could use it. The only data required to calculate our scores are toxicology results and appointment compliance. Both are collected by every responsible provider. We know there are likely other methods that could be deployed, and if there was a better one out there, we'd happily jump aboard. At the very least, our method demonstrates that it's possible to build an objective, standardized, validated outcome measure for opioid use disorder. As a result, all treatment providers that prescribe buprenorphine to treat OUD now have the ability to report the stability of each patient at each appointment. Next slide, please. So what's left to do? This audience has a lot of power. Between the payers, employers, accreditation bodies participating here today, you have the opportunity to ask more from providers. We're eager to engage with you to try to bring an objective quality measure to the addiction treatment space. This is, the graphs on this page show our, these slides got messed up in order, I apologize. This basically shows sort of our signature for all of our patients at a given point in time. And, we think that this looks like we're doing a pretty good job. Essentially, the top half of our patients are doing fine. You don't really get distinction until you get to the sort of next 25th percentile. But we don't really know. We need to be able to compare ourselves to others. All right, next slide, please. This is what I was trying to say before. So this is where I think that this audience can really be very helpful. And we would love to sort of participate with anyone who's interested in talking to us. I think Ingveld made a point in her comments in the chat. She was asking about the point that can this be gamed, and ours can definitely be gamed by other programs if all you do is cherry pick patients. We really want and acknowledge that retention needs to be a part of this, that if you use this in the industry without looking at retention, that it would be far too easy to gain. So, look, in summary, people struggling with OUD, not to mention their families, should have confidence that their provider is looking at outcomes and tuning their methods to make sure that each patient receives effective and personalized treatment. All right, final slide. Here's my contact information. Really appreciate all of your time. And if you have interest in continuing the conversation, these are my contact details. I think I did this in less than 10 minutes. Thank you all again.
Thanks so much, Dan. You did a great job on that.